Perfect. Thank you so much. Okay, my name is Aubrey Page, and I'm going to have my information up here. I should be the biggest thing on your screen. So instead of screen sharing, I'm just going to be right here. So I am an FASD educator consultant, all of those things, and I come through this via lived experience. So I'm going to go over my objectives, and then I'm going to tell you not to sue me, please. So our objectives are to identify the difference between drug and alcohol exposure in the fetus, identify symptoms of fetal alcohol spectrum disorder, and describe the presentation of symptoms of comorbid diagnoses and how they present similarly and differently than FASD. So I'm not a doctor, I'm not a lawyer, I'm not a social worker, so please do not sue me. I have read a lot of studies, and I laughed the fact that I majored in communication and I'm now reading scientific studies for fun. But these are all my social media. Feel free to connect with me there. And also for families that you're working with, I have a Facebook group, the CSH Collab Parenting Neurodiversity. And we have a weekly support group. Like, it's a Facebook group, but we have a weekly support group where people can call in and I give advice. So it's like a free way to get some time with me for families for support. Okay, so I'm going to go over quickly how we're identifying FASD, because if I'm going to talk to you about the difference between FASD and something else, then I'm going to kind of go over the brief description of what it is. So fetal alcohol spectrum disorder is a lifelong disability that affects the brain and body of people who are exposed to alcohol in the womb. Each person with FASD has both strengths and challenges and will need special supports to help them succeed with many different parts of their daily lives. And that definition is from CanFASD, which is Canada's research arm on FASD. They're an amazing organization. And as you can tell from that definition, it both tells you everything and tells you nothing, because it is a spectrum disorder. So there is a broad range of symptoms that could be caused by prenatal alcohol exposure. And so because of that, it's really hard to pinpoint that, and of course the stigma. So if we're looking at it in comparison to other disabilities, it seems like it wouldn't be that common, but actually statistically it's 2.5 times as common as autism, which is a disability that we're pretty familiar with. And so when we go to work on these cases, then I don't want to say, oh, it's very unlikely that it's FASD. Statistically, it's incredibly likely. The only thing that's more likely than FASD is ADHD. So it's not like this is a rare disability that we don't ever want to talk about. And the study this came from was a 2018 study out of UNC Chapel Hill, and it found the conservative estimate was 2 to 5%, and the less conservative estimate was 3 to 10%. And those of us in the FASD community feel like we're closer to 10, but we use 5 as kind of like our benchmark number that we use. So if we look at 5% of the population, that's a pretty significant amount. And in Ohio alone, that's 584,500 Ohioans. That's a lot. That's a lot of people. And do you think that the majority of those people are doing fine in society, or do you think that a lot of them may be multi-system youth, right? So that's why this is a really important topic for what we cover here. So why am I talking about alcohol? Because the concern, especially in Ohio, and understandably, it's opioids. So let's do I'll read this quote. This is from a 1996 report to Congress, which is like, okay, that's a while ago, but still incredibly relevant. Of all the substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. That's not the message we get. We get that drugs are the worst. And the reason is because when an infant is born with drugs in their system, it's tough. Like, physiologically, there's a lot that's happening. There are developmental milestones that are often not met. But when you're born having been exposed to alcohol at some point during pregnancy, you aren't born with any different behaviors per se. It's very rare to have a diagnosis of alcohol-related birth defects, incredibly rare. And so you just don't know. And so then the child goes developmentally along the track. And then at some point, somebody's like, something's off here. I don't know what's going on. So we don't want to discount alcohol as a causal factor. Dr. Chasnoff says that 90% of drug-exposed pregnancies are also alcohol-exposed. So if we have a drug-exposed pregnancy, and that's part of what we're talking about with the case, then we want to assume that alcohol was involved also, because it's incredibly statistically likely. And the good news is that if we're assuming alcohol is involved, there's a broader base of research with FASD, because it's been identified for centuries that alcohol was a cause or a teratogen. But since like 1973, we've been talking about it in regards to a diagnosis. And then another like kind of social point I want to make is that of course we're thinking, well, if more people are using opioids, then we're going to have more babies that are born with FASD because 90% of drug exposed pregnancies are alcohol exposed. I challenge you to consider that if we have more people who have untreated, undiagnosed, unrecognized FASD, a major developmental disability, then perhaps they are using more opioids. And then we are in fact contributing to the opioid crisis by not intervening and supporting these kids. So it's a circle, and in the case of FASD and many things, I'm sure, intervention is prevention. 30% of individuals with FASD will struggle with substance abuse at some point in their life. So getting involved in getting the kid the support they need is critical. And then how do I identify this? Well, one thing I want to cover, I obviously cut out a lot of my presentation to make this shorter. And I have a timer going here because I could talk all day. This does not take that much alcohol. So I was talking to Dr. Larry Bird, who's a kind of a famous researcher in FASD yesterday. So sweet to actually call me and answer my question about something. And he said very few people are properly trained on how to ask about exposure. And even smaller percentage of those are good at it. So if we have asked mom, did you drink during pregnancy? We're going to get a wrong answer. And we weren't good at getting down to the root of what it is. The way to ask, Dr. Chasnoff developed the 3Ps method. And it's a big method, but to boil it down, what month did you find out that you were pregnant? Women don't find out they're pregnant the day they get pregnant. I mean, I've never been pregnant, but like I know enough about science to know that's not true. So that being said, when did you find out that you were pregnant? And how much alcohol did you consume the month prior to finding out that you were pregnant? Right, so we're removing the shame and stigma about it because there is no shame. Until we have an alarm that pops up in our face that we're pregnant, then we can't blame anybody. Until we have 100% efficacy on birth control, we can't blame anybody. I have several friends who have biological kids with FASD. No shame, no blame, we're supporting the family. But we also have to get to the truth of what's happening to get to a diagnosis usually. So I wanted to mention that because a lot of times when I'm in these calls, I'll be like, is FASD something that we should consider? Oh, no, mom's not. No, mom doesn't have to be an alcoholic to talk about FASD. That's the barrier that we have to, the myth we have to overcome in order to have these conversations. Okay, so how is FASD identified? This is a lot of words and I'm not going to go over them all here, but I want to present this idea to you. This was created by Diane Malbin and presented in a book called Trying Differently Rather Than Harder, which is kind of like the hallmark book for FASD. It's like 70 pages. So if you get a wild hair and want to order it on Amazon, it's really fast. My complaint on it is it's got a picture of brains, and I don't like the two brains thing with FASD because one, imagine if my children saw that. Doesn't make you feel good. And two, lissencephaly is very rare with FASD. You can't do an MRI to see, there's no blood test, no genetic testing, and no MRI for FASD. So it doesn't really help us tell the story. So don't leave it out around kids, but other than that, great book. And in her book, she presents this. It's going to zoom in because it's so many words. So she presents primary behavioral characteristics. These are the things that are present because the brain is different, right? We have neurodiversity, and so these things happen. Slow processing pace, memory problems, usually short-term and working memory struggle more than long-term memory. Difficulty generalizing, very concrete thinkers, not understanding cause and effect, perseveration, these kinds of things, mood regulation issues, all of these could be innate, each person's different, could be innate to how the brain functions. Secondary behavioral characteristics exist because these are neurodiverse individuals operating in a neurotypical world with neurotypical expectations on them. And so because of that, they're going to experience fatigue. They're going to be rigid about what's happening around them. They may act out and be aggressive, but that's not necessarily primary to what FASD is. And the tertiary behavioral characteristics are usually where we get involved. These are things where we have an unrecognized, undiagnosed disability. And so we have things like delinquency, trouble at home, trouble at school, social services involvement, wink, wink, you can't see my face right now, substance abuse. The good news is that these things are preventable if we work on early intervention and supporting families properly. And so that's why I'm so passionate about educating people, because you don't know how to intervene until you know what you're looking for. So that's one way to identify it. And then the other way that I like to teach people to identify the effects of FASD are through the 10 brain domains. And this is how Canada does their diagnostic method. Like they use the 10 brain domains to diagnose people. And I think it's just way smarter than how we do it in America. In America, there's like 4 or 5 different models to diagnose people. I prefer the Hoyne method, and if anyone's asking me. The first 6 of these are neurocognitive domains in the DSM. So these aren't like arbitrary things that were made up. In Canada, how it works is if you have 2 standard deviations below the mean in 3 out of these, and then the confirmation of prenatal alcohol exposure, then you can be diagnosed. Most individuals qualify in 7 of the categories. So with executive functioning, we understand how that works. I'm going to talk a little bit later about how executive functioning presents a little bit differently in FASD versus ADHD. Memory, I talked about short-term working memory and how that's more difficult. Of course, memory is part of executive functioning as well. Social cognition, right? Like our social skills are not going to be on target. Usually expressive language is excellent. Receptive language struggles a lot. Attention span usually struggles a lot. And so then we think ADHD, but not ADHD. Neuroanatomy and neurophysiology, facial features only affect 10 to 15% of individuals. So unfortunately, if we don't have confirmation, we have to diagnose based on facial features, but we're missing a huge swath of people. So most of us operate, only about 1% of our population is diagnosed, and most of us operate under suspected FASD. You can't get services based on that, but we know that we're parenting different and there are different interventions for this child because of that. It sucks, but that's just the reality of what it is. Proprioceptive issues, vestibular issues, those are all going to be concerned. Interoception, so like incontinence, we're thinking like, oh, this is a behavior issue, but like maybe the body and the brain are not talking well. And so therefore this is happening. And then we're treating it like it's a trauma response when it could just be that physiological difference. Cognition is 1 of 10, right? 1 of 10, guys. You don't have to have an IQ below 70 to have FASD. It's a myth, it's a rumor. The range of IQ for FASD is 20 to 120, and 70% of individuals with FASD have an IQ over 70. So we're just throw that out. It does you no good to think in that context. And what happens is people are saying, oh, no, they're too smart to have FASD. What does that mean? Like you say people are too smart to have autism, it just doesn't make sense. So the brain is more complex than IQ, so just and then academic achievement, of course, you're going to struggle with that if you're struggling with everything else. And then the newest addition is affect regulation or mood regulation. There's, the difference between people expecting you to perform neurotypically when you're not, and the frustration that comes from that. But then there's your brain just randomly goes, and you can't regulate your feelings as easily as everyone else. And so that is one of the newer additions that they've done to help diagnose kids. Okay. So now I'm going to talk about diagnosis, and this is the Hoyne method that I'm showing you here. I like this. This came from a medical manual that I have linked on my, when I say my website, I am the CEO of the Change Tertiary Collaborative, and our goal is to focus on all neurodiversity because the interventions that I teach for FASD are actually helpful for ADHD, autism, ODD, blah, blah, blah. So on the cshcollab.com under resources, you can get to this medical manual. So it's going to get bigger because obviously it's tiny right now. Okay, so on this, you can see that the plus is things that need to be present in order to get that diagnosis. And we're not going to spend a super long time on this right now because I'm looking at my time and I'm getting close. But I want to show you that there are like if this, then this, and that there are several different, it's an umbrella of diagnoses. So there's 5 different diagnoses, and you can diagnose with confirmation and without confirmation. So if you're interested in that, you can dig in a little bit deeper as to what that looks like. Challenges to diagnosis include location. There are 3 clinics in Ohio that diagnose FASD, and they're all up north, nowhere within 3 or 4 hours of me. I live in Cincinnati. Comorbidity is we're gonna think that it's something else, even though this may be the root. The myths that and the stigma that I've been talking about today, and then confirmation of prenatal alcohol exposure. If the child's not in a biological home, that's gonna be difficult to achieve. This term is my new favorite giant word. It makes me sound really smart. Diagnostic overshadowing. This happens a lot with FASD. This person's nodding. They've heard this before. Good, because I'm like, whoa, I'm so smart. Okay, where healthcare professionals attribute symptoms to a mental health condition when other comorbid, often physical or developmental issue is also present. So what happens with FASD is we see this. I went to a meeting with doctors one time and they said, diagnosis is a cluster of symptoms. So as far as the cluster of symptoms goes, most of our kids qualify for ADHD. That doesn't mean that's the causal factor, right? That's not the root of it. And so if we miss the root because it looks like trauma, it looks like ADHD, it looks like autism, then we don't get the solution that we're looking for. Okay, so then let's look at comorbidity. When I talked to Dr. Bird yesterday, he asked me this, so I actually updated this just this morning. The question is, does this child have FASD? And if so, what comorbidities do they have? It's not, okay, they have ADHD and FASD. FASD is kind of the roots, and then everything comes out of that. In general, there's a high likelihood of vision impairment, hearing loss, communication deficits, all of those sort of things with FASD. And I'm going to keep going because I'm running short on time. 49.4 to 94% of children with prenatal alcohol exposure also have an ADHD diagnosis. Not to say that they have ADHD in the traditional sense, but they have the presenting symptoms of ADHD. And if we look at the symptoms of ADHD and FASD, the top box is the symptoms of ADHD that are more significant in the population that was exposed prenatally to alcohol. ADHD was more significant in focus and sustain and in executive functioning. And then they also had their adaptive functioning skills improved over time. So that's also a plus. So not that there is no issues with focus and sustain in the FASD population. It was just more significant in the ADHD population. So I'm going to give you a handout that has all of this because it's a lot of information to digest. And then it's going to have, you're going to be able to click on it and it's going to take you to this. I had the handout and then I updated a little bit based on my conversation with Dr. Bird yesterday. So we'll send that out when we do the video. A very important thing, medication does not work the same in FASD and ADHD. If you have FASD and ADHD, then you're probably going to have success. But they found that in this study, if you want to get super nerdy and that's your jam, you can click on it. But methylphenidate was something that didn't work super well for individuals with FASD. So you want to do more research on medication responsiveness, and I have a great tool for you because there's actually an FASD medication algorithm, which is brand new. It came out last year, and it's worked really well for a lot of the families that I work with. So I'll have the link for that in the worksheet for you as well. Can FASD came out with that. With autism, 72% of children with FASD also meet criteria for autism. It's an incredibly overlapping diagnosis. And so on here, I tried really hard. How do I show you the differences and the similarities? And there are so many similarities, it's difficult. Differences, FASD is associated with microcephaly. Autism is associated with macrocephaly. Obviously, FASD is much more common. You know, there's a couple differences, especially about how we diagnose it, but so many of the symptoms are the same. One thing I added on the worksheet in here is perseveration, because that's something we think about in regards to autism, but trust me, it happens with FASD. I have 2 of them downstairs. So sensory processing, speech and language, all of these things they are true in autism and they are true in FASD. And that's why it can be really hard to distinguish the two. A major distinguishing factor that often separates our kids is that individuals with autism are often socially avoidant and individuals with FASD are often seeking out social situations. That does not mean that they're good at them. It just means that they're seeking them out, right? We still have the social cognition struggles, but they just really want to connect with people and are very often very gregarious. So that is my my quick spiel. I know I'm probably way over time. This is a little picture I like to show on how we get from FASD to ODD, because we expect kids are able to do X, Y, and Z, and they can't. And so we get them in trouble, and then they fight us back. And then this was developed by Diane Malbin. We get rigid defensiveness, and then we get diagnosed with ODD. So that's another comorbid diagnosis that if we could identify the root cause as FASD, ideally we could avoid it. So I'm going to pop up my stuff on the screen, and then I think we have questions or no questions.